everyone. Welcome to this launch of the Framework for Collaborative Action on Tuberculosis and Comorbidities. My name is Pradhan Mantri. I work for the WHO Global TB Program based here in Geneva. And without further ado, I will hand over to the Director of the Global TB Program, Dr. Teresa Kasaeva, to give us some opening remarks. Dr. Kasaeva.
Thank you very much, Farai. Good morning, good afternoon, and welcome, dear colleagues and friends across the globe to this important launch of the Framework for Collaborative Action on TB and Comorbidities. A comprehensive people-centered care and prevention is one of the core fundamental principles of the health and of the sustainable development, both universal health coverage principles, one of the basic and fundamental, as I've told. And it's the heart of the WHO NTB strategy. Member states have committed in multiple documents and strategies to assure people-centered care for people, for addressing TB, comorbidities, also in the respective UN high-level meeting declaration on TB, non-communicable diseases, and HIV. Ensuring that people with the TB and comorbidities receive high quality and coordinated care is important for the best possible outcomes for people with multiple diseases. And quite frequently, because TB is affecting the poorest, these people have multiple morbidities, and instead of going from one facility to another facility, that's absolutely essential, especially learning lessons from the recent COVID-19 and ongoing COVID-19 pandemic, that we really need as soon as possible this patient people-centered approach. Dr. Ed, we can see and hear you. Dr. Ed, we can see and hear you clearly. So thank you for joining us.
Where's the volume?
Dr. Ed, we can clearly hear you. So, colleagues, some technical issues, but please give us a few seconds to fix them. So, yes, meantime, I can continue with your permission. Global Tuberculosis Program released the 2022 Global TB Report just recently in October. This report highlights the important and the role of comorbidities and other determinants in driving the TB epidemic globally. And it also emphasizes the importance of joint efforts to address effectively TB and other comorbidities. The 5 main health-related risk factors and drivers of the TB epidemic outlined in the Global TB report are alcohol use, diabetes, HIV infection, smoking, and undernutrition. These 5 risk factors accounted collectively to almost 5 million of the estimated 10.6 million new TB episodes in 2021, with undernutrition alone accounting for more than 2.2 million of the overall incidence cases. In addition, there are also a number of other important TB comorbidities, such as substance use disorders, as I've told, chronic respiratory conditions, including silicosis, viral hepatitis, and mental health disorders. You can and we can and we must respond to this burden of TB and comorbidities. And we must say that while we have strategies highlighting the important high-level political documents and strategies, we have policies to address TB and comorbidities. However, we see that the uptake and scale-up has been slow. Probably the one exception and positive example, which brings us hope that also that we can move forward more effectively and faster, is the example of collaborative actions for TB and HIV activities. And we've started this work earlier, and we can see already very good practical impact. The other risk factors and comorbidities should not be ignored, not only due to this number of people that contribute to the overall the TB epidemic, but also we are looking at other important data. For example, the number of people with diabetes, for example, is estimated to increase by 150 million up to 2030. Given the 2-3-fold increased risk of TB among people with diabetes and the impact of these diseases synergy on treatment outcomes, this represents a considerable challenge when we are aiming to end TB by 2030. While the COVID-19 pandemic's impact has yet to be fully realized, and with the rise of global conflict in many parts of the world, there has been a dramatic worsening in global hunger, with an estimated more than 800 million people who were malnourished last year. These people have 3 times higher risk of developing TB compared to people with adequate nutritional status. Many of these people were living in high TB burden countries. Mental health and substance use disorders have a devastating bidirectional interplay with TB, as well as an increased association with the poor treatment outcomes. Not to mention to the debilitating stigma that is often endured by people with TB and these conditions. While these have been orphan areas in the past, they should not be any longer like this. People with TB and comorbidities may also have long-lasting effects due to the interaction of both diseases, including long-term impairment of TB-associated disabilities. Our new framework outlines how to establish and strengthen collaboration across the health programs, organizations, and sectors to deliver integrated people-centered services with the ultimate goal of decreasing the joint burden of TB and comorbidities in line with the TB strategy targets and the United Nations high-level meeting commitments described above. A framework was developed following the core principles of WHO development by WHO policy guidance based on evidence through a really very inclusive and transparent process with close collaboration with multiple stakeholders, including civil society, experts from different health sectors I've mentioned, also partners, donors, and researchers. As recommended in the framework, a country should also, based on this document and tool, they should develop their national plans and activities for TB and related comorbidities. And then we will see the clear impact of this work in practice. At the end, I must say that we know it very well that people with TB, as I told, quite rarely present with just TB, and they have multiple morbidities. And in the current situation of post-COVID and ongoing crises with the growing socio-economic crisis and problems, we can't ignore these circumstances, and we should find more effective approaches to address this. Business as usual is not working anymore. This launch is not just for celebration of our work, it's not just the end of the story, it is the beginning of our journey. I hope that you will use and apply the framework as well as the latest WHO recommendations on TB, comorbidities, other diseases, because our main purpose is to save lives, to improve outcomes, and to provide the better and longer, healthier life. Thank you very much for your interest. Thank you for joining us today, and we are looking forward for very interactive discussions with really very important high-level representatives, including from the countries and my colleagues, directors from other departments. So with this, I will stop and hand over back to Farai.
Okay, thank you so much, Teresa, and once again, welcome to the colleagues who have joined since the beginning of the webinar. This is a bit of a mixed feelings that I do have at the moment to be inviting the Assistant Director General for Universal Health Coverage, Communicable and Non-Communicable Diseases Division in WHO. We are privileged because for those who might not know, today is Dr. Ren's last day in office in this capacity. So we are really honored to have him. And also, I think we really appreciate the commitment. I think for those of us who have moved jobs, we know how busy and hectic the last day usually is. So we really appreciate the commitment that he has shown, not just today, but throughout his tenure in supporting work within the department, but also within the division overall. So we are really honored to have Dr. Ren. So I'll now invite Dr. Ren to give us his opening remarks, and maybe also, hopefully it's not the last time that we'll be engaging him in talking about TB and comorbidities. Dr. Ren, over to you.
All right, thank you, Farai. I hope you can see me and can hear me now.
Yes.
It's okay, right? Can you see me and hear me well, right? Okay, thank you very much, distinguished colleagues and friends. Good morning, good afternoon, and good evening from Geneva WHO headquarters. And thank you so much for joining us for this very important webinar for the launch of a framework of collective action on TB and comorbidity. I'm so happy to see Bente and other colleagues from other departments join in the rooms for this very important launching ceremony. I appreciate your attention as well to all the colleagues, friends who attending these webinars from different parts of the world. As Dr. Kasayeva just mentioned, collectively, HIV, malnutrition, diabetes, and smoking and alcohol use disorders accounted for approximately 45% of new episodes of TBs in 2021. In addition, up to 70% of people with TB has been found to have a mental illness. People with TB all too frequently suffer from comorbidities or multi-morbidities, which can have devastating consequences on their health outcomes and quality of life. Accessing the necessary care is often more challenging and stressful due to the need for the reference from one clinic to another. But it's public or private, incurring extra financial burdens and time. TB has been leading cause of mortalities from infectious disease well before the COVID. But it has taken the COVID pandemics to remind the world just how critical it is to have a resilient health system to combat the infectious disease. A strong response to communicable diseases such as TB and COVID is of paramount importance, but also close to the impossible when the health system is weak. For universal health coverage to be truly universal, the shift is needed for the people, with people. The framework for collective action on TB and comorbidities also aims to do just this, and to ultimately to elevate its burden on the patients along their pathway of care and increase access to high quality care for people with TB and comorbidities at a time and a place, at the right place, and at the same time, and contribute to improved quality of life after TB treatment ends. To do this, we need to work together across different disease areas, including mental health and non-communicable diseases, across the health systems, across sectors, with civil society, with patients, groups, to leverage synergies and offer people with TB and comorbidities is high quality care. We need to build on the primary health care platforms to decentralize the vital care for the people with TB and comorbidities, and at the same time, build on strong network of TB services to extend access to services for these comorbidities, in turn strengthening primary health care network. To finish, the development of this framework is just the beginning of the journey. I hope you will use and apply the framework as well as the latest WHO recommendation on TB and the comorbidities in efforts to improve outcomes for people with TB and the comorbidities. With that, I thank you very much for joining us. I said today will be my last official day working in WHO, but I will be with you to end TB and the other public health issues in my different role to play in the future. Thank you very much.
Okay, thank you so much, Dr. Ren, for those remarks. And once again, thank you for your support throughout your tenure. And we will try and continue with the work and the example that you've set for us going forward. Okay, I think we will now move on to the next session for this launch webinar. And for this session, I'm pleased to welcome some 4 distinguished panelists. Once again, thank you for your availability. This framework for collaborative action on TB and comorbidities was developed with input from various stakeholders, including affected communities, national TB programs, as well as input from various disease programs that have informed the work that will be presented here today. So joining me for this panel discussion, we have we are going to hear from somebody who has actually experienced TB and also comorbidities. He'll tell us a bit more about that. That's Ashish Ashna, who is a lawyer, but also a public health professional who has lived experience with TB and other diseases. We are also going to hear from national TB programs. We will hear from the Zimbabwe National TB Program Manager, Dr. Fungai Kavenga will be joining us as part of this panel discussion. We'll also hear from India, Dr. Sanjay Mathu will also join us for this discussion to share perspectives related to TB and undernutrition. And finally, we'll hear from Georgia, where we'll also hear about perspectives regarding comorbidities, particularly HIV, hepatitis, and STIs as they relate to TB. So to start off, Ashna, could you please share your perspective as someone who has experienced TB, but also related comorbidities from a patient's perspective? Ashna, over to you.
Thank you so much. Good morning, good afternoon, good evening. Thank you so much for having me here. Am I audible to everybody?
Yes, you are.
Thank you.
Please go ahead.
So I'm Ashna Ashish. I'm a lawyer, a public health professional, and an MDR TB survivor. I'm also somebody who was on treatment for depressive episodes before I got TB, while I was on TB treatment, and after. So I'm here to talk today about 3 things, and I'm going to make it really quick because I realize we're on a tight agenda. The first thing that I'm going to talk about is the survivor perspective of TB and comorbidities. In my case, it was mental health, so TB and mental health. The second piece that is going to be part of my talk is why we need to manage these comorbidities together. And the third is going to be the how of it. from the perspective, not just of a survivor, but somebody who's been working in public health for a few years now, closely with the community and the program. So I was diagnosed with MDR-TB when I was fairly young. I was about 24, just going on to 25. For me, it was, the diagnosis aside, the side effects with the DRTB medications actually impacted my mental health quite a lot. But I don't want to go into my specifics particularly. What I will do is give a bird's eye view, because I do want to give a comprehensive account of what happens for survivors across the board. So let's start with the fact that, TB and mental health have a bidirectional relationship, right? So you've got someone with a mental health issue, if they have poor access to nutrition or they don't have access to safe housing, they're more likely to be prone to developing various illnesses, and one of them is TB. TB, on the other hand, has a way of affecting your mental health at every stage. So you've got the diagnosis, which in itself is a shock for many people. There are studies in the Indian context, this is particularly from a Chennai cohort, where people who were diagnosed with TB, their responses ranged from shock, denial, to even feelings of suicide. This is just at the stage of diagnosis, before any treatment has started. And moving on, when you come to the treatment, drug-sensitive TB, it's 6 months, but that's still quite long. DR-TB, on the other hand, is anywhere between 2 years to 7 years, 2 years at a minimum. And in countries like India, what we call the new drugs, bedaquiline, delamanid, which are now practically 10 years old, are still not available as universally as they should be. So we're put on longer regimens, which include injectables and painful injectables with side effects. And the longer regimen, of course, as you all know in this room, is incredibly toxic. It impacts mental health indirectly, in that all of these physical side effects wear you down emotionally, they exhaust you. You're fighting a disease already, and now you're also fighting the side effects of that disease. But more specifically, medications like cycloserine directly impact mental health. They're known to be correlated with depression, psychosis, breakdowns, feelings of suicide. So all of this comprehensively, whether you look at it with, even for somebody who doesn't have a mental health issue, once they're on TB treatment, it's quite a challenge. Now, when you put in the mix that they already had a pre-existing mental health issue and then they're put on TB treatment, this tends to aggravate their mental health issues, and in turn affect their ability to be able to do what's necessary to keep themselves healthy and complete treatment. Which brings me to my second part, which is, why do we need this? Why do we need to deal with it? And particularly, I'm going to talk about mental health, because with the others, with diabetes, HIV, we seem to have this intuitive understanding that, okay, of course you need to deal with them. Without that, there is no good outcome. But when it comes to mental health, we often have the, mind over body approach, or mind over matter. So just cheer up, or just tell yourself to feel good, which I think is kind of like telling a person with diabetes to just will themselves to produce more insulin. It's as unscientific as that. And if that doesn't work, neither does telling people to cheer up. What we do need is to be able to equip people with the kind of quality of life that they deserve, and that they need to be able to finish these treatments successfully and go on then to live better, healthier lives. The reason that it's important to manage TB and MH as comorbidities is that there's a twofold reason. One is, of course, the argument that no human being should have to go through the indignities and the suffering that people have to go through when they deal with TB and mental health together, or TB and any other comorbidity together, or just TB for that matter. It affects your quality of life. It affects your will to live. There are days where you wish, I wish this would just end, and taking your chances with the illness seem better than going through the treatment that affects your mental health in ways that is soul numbing. But practically, even if we look at it from a public health perspective, or as TB elimination, it makes pragmatic sense to prioritize mental health. This isn't about feel good hypersensitivity. It's about the fact that if you have somebody who can't so much as get out of bed, how are you going to then count on them to take their pills, to take the food they need, to be able to combat this disease in a healthy manner? So both from a humanitarian perspective and a public health imperative, it's critical that we support persons with TB in dealing with TB and the treatment side effects, as well as managing the comorbidities that they may have. This brings me to how. So I'm somebody who's associated with a collective called Survivors Against TB that's based in India. It's one of the first survivor-based collectives that has been working to create awareness about TB and advocate for the needs of persons affected with TB. We work with a group of TB survivors as well as experts. And part of our work on TB and mental health, apart from insisting that they should be dealt with as comorbidities, because the science is in and the evidence demonstrates that they are indeed comorbidities, and that one affects the other. So what we've been doing is we've been looking at what kind of support do persons affected by TB need, and so I'm going to be drawing on some of that work when we look at dealing with TB and MH as comorbidities, and some of this stuff would ring true even for dealing with TB and any other comorbidities. The first step, right, would be integrating screening. So integrated and coordinated care, and integrating these screenings at the primary healthcare level, that is critical. In terms of TB and MH screening, I can speak specifically to the Indian context here. We are short-staffed when it comes to mental health professionals. If you look at the population to psychiatrist ratio, it's very skewed. And one of the things that is important here is with limited resources and the kind of burden that we're already facing, be it in terms of public health infrastructure or with COVID, it's critical that through task sharing models or through community-based initiatives, we sort of equip health workers and the community to do a basic screening, right, for persons affected by TB. Again, the screening has to be adapted to the local context. So they did this in Nepal, where initially they tried to screen for depression and anxiety, and they came up with nothing. There was no response. And they knew there was something off there. It couldn't be that nobody had any of this going on. And so they adapted it to the cultural context, which is words like dukh and samasya, which means sadness or problems. And that resonated better. Like I can even say in India, I don't think immediately if you use depression, because of the stigma around mental health, people may not be volunteering or coming up with that kind of information. But if you talk to them about stress, future worries, fears, that's more likely to resonate with them. So screening tools that are adapted to the local cultural context and community-based screening initiatives in countries with limited resources, that's one. Two, coordinated integrated care, so even during treatment, like right from diagnosis. First, there has to be some counseling and diagnosis, and I don't mean just the basic, this is what TB is, but also dealing with the mental health impact of diagnosis on a person affected by TB. Then during the treatment, periodically there needs to be counseling. So let's say, like we have tests for side effects, right? We monitor liver function, kidney function. Why aren't we monitoring mental health the same way? Why aren't we having a person check in with their counselor, or if needed, if a referral is needed, then their psychiatrist every couple of months? Why is that not happening? It's just as important. We do know now increasingly that mental health has an impact on physical health. It's not just something in your head. And your head is very much part of your body. So even if it's something in your head, that's still a problem, right? And the third thing that we tend to sort of forget is, and I can speak to this, is residual mental health issues. So when you've been on that cocktail of antibiotics for 2 years, when your life as you know it has changed, with DRTB, mortality levels are higher, and you've been through something that is just such a whirlwind and a roller coaster, and not in a good way, that it takes a while before you get to some sense of stability. For me personally, I mean, I stopped treatment in August 2019. I was declared, I mean, I've successfully completed my treatment, but my mental health was in shambles for about 6 months. It took me 6 months to be able to reach a place of stability, just to deal with the after effects of my TB treatment. So residual sort of mental health support, of course, spaced out at longer intervals when you go for your regular follow-up or when you're going for your CXR. That is something that needs to be brought into place. And apart from all of this, so this is like programmatic stuff that can be done. But apart from all of this, in terms of dealing with the stigma and you know, the public awareness about it, what needs to be brought in is that mental health is just as important as your physical health, and actually is not divorced from it. It's integrated within that space of physical health itself. So to watch out. I mean, public awareness campaigns that tell people what can you watch out for. I'm somebody who'd been working in health and interested, my research interests lay in health even when I was, studying law. So I picked up on it pretty easily. For me, the struggle was not identifying it, but dealing with it. But for a lot of people, the struggle is just labeling it. They have no idea what's happening. And I can't imagine how scary that must be. I was at my wit's end even when I knew what's happening to me. And I had the resources and the privilege and the means to be able to cope with it. So educating people, persons affected by TB, on what these issues can be, educating health workers, health providers on dealing with this just as seriously. Someone comes to you with chest pain, you wouldn't tell them, you know what, go home, sleep it off. But someone comes to you telling you they feel depressed, chances are the doctor might say, you know what, go home, sleep it off. And chances are we say that, not just doctors. I mean, you tell people to just, get a move on and man up and other toxic variants of this. But so it's time to take it as seriously, because if we want to eliminate TB, we have to look at this more comprehensively than just TB as a clinical disease. We know now that this is not true. We know that there are socioeconomic determinants to TB. We know that socioeconomic determinants mediate and affect access to healthcare. So an integrated, coordinated response to this and dealing with them as comorbidities is very, very critical. And I'm glad that WHO and all the country programs are taking this first step towards that. And I hope to be a part of this journey, and we'd be happy to do anything we can to support this. Thank you so much.
Okay, thank you so much, Ashna. I think well said, well spoken. I'm sure there are a lot of people who might have questions, would want to learn more. So colleagues, you are free to post questions in the Q&A if you have any questions that you would like Ashna and indeed any of the panelists to respond to. So moving on to hear from a TB program perspective, Dr. Kavenga, would you please share with us your experience providing services for diabetes and TB, and maybe highlight the key challenges and issues that should be addressed to improve people-centered services for people with TB and diabetes, maybe in the next 4 minutes. Dr. Kavenga.
All right. Thank you very much, Mr. Chairman. First, I would like to congratulate the WHO for coming up with the framework for collaborative efforts to manage TB and comorbidities. So I'll quickly take you through experiences from Zimbabwe, as introduced earlier. I'm Fungai Kavenga, and I'm the NTP manager in Zimbabwe. So in Zimbabwe, we have a TB, DM, HIV triple burden. As you can see before your screens, the relationship between TB and HIV, which we all know and appreciate. Then the TB, DM relationship. We're also aware of the relationship between HIV and diabetes. So this is just the rationale for TB-DM bidirectional screening in routine care. I won't labor much on this, but maybe just to remind people that diabetics have a 2 to 3 times higher risk of developing TB compared to people without diabetes. And if they do develop TB, they tend to have a more severe disease and they're at higher risk of drug-resistant TB. So in our country, we piloted TB-DM bidirectional screening between April 2016 and September 2017. So for those patients who were notified with TB and screened for diabetes, the number needed to screen for diabetes was 12. Then for those DM patients who were screened for TB, the number needed to screen was 18. So this is just to emphasize the importance of TB-DM
bidirectional screening and the related high yield. So we then took a decision to roll out TBDM bidirectional screening. So we took the approach of introducing this bidirectional screening in our integrated TB HIV care sites. So we went on a drive to build capacity in healthcare workers through one-day classroom learning activities, and this was followed by 3 days attachment at centers of excellency, then a one-day feedback meeting. So to date, 16 sites have since been sensitized and are carrying out this TBDM bidirectional screening. So our health facility registers do capture this information. We have our quarterly report form captures the same information. So that means all that TBDM information enters in our national health management information systems, and we're using the DHIS too. So this is just showing the yield, the TB yield amongst people screened amongst them people screened for diabetes. As you can see, the yield for TB cases amongst diabetic patients as of 2021 was around 2%, falling from 6% in 2020. So the challenges we have experienced in our rollout, I think the biggest one is capacitation of healthcare workers is limited. As I highlighted, we've only managed to build capacity in 66 facilities, and I think we need to do more. Then there's also the issue of consumables, particularly glucose strips and glucose tips, is limited. Excuse me. So this was previously, the distribution was previously done during trainings, and there was no continuity in supplies post-training. Then there's also limited availability of diabetes medicines at facilities, and we believe this demotivates clients to go for TBDM bidirectional screening. So our plans as a country, we want to further scale up TBDM bidirectional screening in all our health facilities. We particularly want to prioritize high impact facilities, those with high OPD, high outpatient department attendances, and those TB HIV clinics with high attendances. We want to target high volume district hospitals and primary healthcare facilities. We also want to target those districts with a higher TB burden. We want to strengthen reporting in TBDM collaborative activities, as well as strengthen the supply chain for TBDM comorbidities. I thank you.
Okay, thank you so much, Dr. Gabenga, for sharing that. It's actually very encouraging experience from Zimbabwe in terms of addressing TB and diabetes. Again, in case colleagues have got any questions, comments, please post them in the Q&A, and hopefully we'll have time at the end for our panelists to respond to those questions. So moving on to India, Dr. Sanjay Mathu from the NTP, how have you been addressing TB and undernutrition in India? And based on your experience, what are the critical enablers for collaborative action on TB and undernutrition? Over to you, Dr. Mathu. In case you are speaking, Dr. Sanjay, we cannot hear you. If you could kindly unmute yourself.
Am I audible now?
Yes.
Yeah.
Loud and clear.
So friends, good morning, good afternoon, and good evening. Thank you, WHO team, for arranging this launch and providing Team India the opportunity to make a presentation on this comorbid conditions of the tuberculosis and undernutrition. So, moving. So, if we are seeing this a situation of the undernutrition and tuberculosis in India, we are having a large number of the persons who are having undernutrition, and we are having a large number of the persons who are having tuberculosis. We are having National Family Health Survey in India, which is taking some of the parameters countrywide for the health conditions, and undernutrition is one of among those conditions. We can see this line diagram is there, where this blue line is showing the prevalence of the undernutrition among the less than 5-year child. First National Family Health Survey was done in 92-93, where 51% of the under 5 children were having this undernutrition. And over there, we have decreased the percentage, but still by the last NFHS 5, which was done in 2019 and 21, we have still having 32% of our children of less than 5-year age are suffering from undernutrition, and they are under the category of underweight. When we are seeing situation in the reproductive age group of the male community, in the National Family Health Survey 2, which was done in 1999, and it was 35.8% male were having the BMI less than 8.5, and still by the fifth survey we are having 18.7% of the male age under less than BMI with less than 18.5. In female, it is from third survey we were at the 28% female were having this underweight, and then as per their BMI criteria, and still by the fifth survey there we are having 16.2% as a female with the undernutrition. And if we are seeing this global TB report 2022, it was estimated in 2021 approximately 3 million TB cases were there in India, and it is obvious factor and well-known information that TB and undernutrition are having very complex situation. Both are predicting and making the situation worse for other conditions. It is vicious cycle, like undernutrition leads to development of tuberculosis, and tuberculosis again leads to undernutrition. If the person is having undernutrition tuberculosis, the course of the disease is also more serious. We are having more adverse effect. We are having more complications, and the outcome is also unfavorable. If we are saying in India, almost 25% of the tuberculosis are attributed to the undernutrition as per the Global TB Report 2020. So this factor has been very clearly highlighted in our national strategic plan, and we have taken some steps to manage these situations. Like we are having a national guideline for nutritional care and support for the patients with tuberculosis in India. These guidelines basically provide the information how the assessment and counseling of the TB patients may be done for undernutrition. It is also providing this operational aspects of the implementation of nutrition support to the TB patients. We are also having this mobile-based applications. One is having NTB, N is for nutrition for tuberculosis, where the patient's assessment may be done, and it is providing a regional and contextual based information how the nutrition support may be provided to particular patients. We are having one more mobile application is there, which is TB Arogya Sathi app, and we can have the assessment of the nutritional condition, and similarly the information how this undernutrition may be managed in the TB patients is also available through that second application also. So India is one of the country which has started one of the nutrition supplement program in the TB program. In 2018, by 1st April, Government of India launched one Nikshay Poshan Yojana scheme, where we are giving Indian national rupees 500 per month to all the TB patients, and this incentive is provided to a complete duration of the treatment, so that patient can take some of the supplementation, and this complication of the undernutrition may be decreased. This is done digitally, and the money is going directly to the patient's bank account through the DBT. If we are seeing how much of the benefit has been given, and to see the volume of this scheme, almost 7.1 million TB patients has achieved the benefit. And if you want to see that how much of the money has been distributed to the TB patient under this scheme, it is 18.7 billion international rupees has been so far distributed under the scheme to support undernutrition in the TB patients. Then we are having another scheme. It is the countrywide scheme. We call it Pradhan Mantri TB Mukt Bharat Abhiyan. And basically this campaign was launched by our Honorable President in the month of September. And here we are basically appealing to the community to come forward, so that these TB patients may be provided some community support. When we are saying the community support, it can be provided as a nutritional support, like they may provide some additional ration or the nutritional supplement to the TB patient. It may consist of cereals, pulses, nuts, vegetables. Other than this nutritional supplement, they may provide some micronutrient supplement also, and they may also provide some supports to the patient, where like if patient is not able to go somewhere, so during the transportation some additional help may be provided by these communities. Who may be these supporters? Like any industries, NGOs, even individual from the community, or in the private sector, or the public service providers. Anybody can come forward, and as per their capacity and their willingness, they may adopt the TB patients. So if we are having Niksha system, where we are obtaining the information and the consent also from the TB patients, like if we can see 77% of our TB patient has provided consent that they want to receive this community support, and their address may be shared, residential addresses may be shared with the these community supporters. And so far, if we are seeing, almost 46,000 a supporter has come and has registered that they want to support these TB patients. Other than this, we are having some state-specific schemes are also there, where there's some nutrition supplement is being provided to the TB patients. Then we are having some collaborations with the other programs also, like we are having Line Ministry, which is Ministry of the Women and Child Development. Under this, there is one ICDS scheme is there, Integrated Child Development Scheme, where this under 5 child are being provided the nutrition supplement. So in this also we are having a nutrition supplement to the TB patients, and when the malnutrition is more, then the ration is also providing adequately. Then we are having other program is RPSK, we call it the Rashtriya Bal Suraksha Karyakram, where this is the mobile health teams are there. They are making visit to the patients' houses, and they are also making to the primary school children's, like up to the 5th standard of the school children's, where they are doing the assessment for the TB and the undernutrition, and accordingly they are linking these such patients to both the program. Then we are having Rashtriya Kishori Suraksha Karyakram. Under this is basically this is a program for the adolescent age group children's, where we are having standalone facilities are there. We are having this adolescent friendly clinics are there, where these patients are again being assessed for the undernutrition and the TB, and we are having linkages and support to such patients. Then we are having another program is there, the Nutritional Rehabilitation Center program is there, where we are having the children who are suffering from the severe acute malnutrition. Under these, the patients are admitted, they are regularly screened for the tuberculosis at the regular interval, and they are also provided this adequate nutrition supplement during the 2 weeks admission. And then after that, they are being provided this counseling, how this undernutrition may be managed. And then under the ICDS scheme, the additional ration is also provided to such patients. So coming to the some of the challenges, like we are doing these activity, but still we are having some of the challenges. When we are having this Niksha Poshan Yojana, where we are providing this monetary benefit. So the question has been, and there has been discussions of the adequacy of the 500 Indian national rupees per month, if it is adequate to give that nutrition supplement, that is being discussed, and some expert has raised the voices that we need to increase this supplement. Then another question is being discussed when we are providing this monetary benefit, how it is being utilized. If it is being utilized properly for the nutritional purchasing only, or if it is being utilized for some other causes. And then who are using these nutrition supplement, if they are buying it, if it is only TB patients or other family members also using. So these are some challenges. Then other than this, what we are having, another major factor is there, like a TB patient is there and undernutrition is there. We are having schemes and initiative for such patients, but it is very well known fact that undernourished patients, they are more prone to develop the TB disease. So what is the schemes and the initiatives and the activities to be done before the TB infection is occurring to such patients? In India, we are having certain schemes are still there for such patients, like we are having Antyodaya schemes. It is a public distribution system. We are providing some nutrition ration at very low cost or free of the cost to the below poverty line people. So these are the some schemes, but still we need to give some more focus on these such patients where the TB infection has not occurred. So when India is looking forward to have or achieve these NTB targets or SDG NTB targets, we are having this undernutrition is one of the major challenge when we are looking after this, and we need to have more focused approach to manage these comorbid condition of the undernutrition and tuberculosis. Thank you very much for patience listening.
Okay, thank you so much, Dr. Matu. I think that has been really enlightening, and also congratulations for the initiatives that you have taken to address undernutrition in the context of TB programs. No, it is really, really encouraging to see the work that you're doing, and I'm sure a lot of colleagues will be interested to learn a bit more in terms of what can be done in other settings and other countries. So thank you so much for that. There are quite a few questions in the Q&A. So I think for the panelists, for those that you are able to respond to, I would encourage you to respond in the Q&A in case we don't manage to have these questions addressed live. The last panelist in this session is Dr. Akaki Abutize. Dr. Akaki, Georgia is reported to have made significant progress in jointly addressing HIV, hepatitis, and TB. Could you please share your experience in this regard and how, in your view, this can be improved and sustained? Over to you, Dr. Abutize.
Thank you very much. I hope you can hear me well. Dear colleagues, once again, thank you very much for inviting me to at this very important webinar. I will try my best not to exceed 4 or 5 minutes. And let me very briefly present Georgia's experience and scale up of integrated screening and care for tuberculosis, hepatitis C, and HIV. Georgia has high prevalence of hepatitis C. Georgia belongs to high burden tuberculosis country, and we have low concentrated epidemic of HIV/AIDS. The prevalence of TB/HIV co-infection is around 3%. 21% of tuberculosis patients are also co-infected with hepatitis C virus. And it should be noted that there is a very strong collaboration between tuberculosis and HIV services, including HIV screening of all people with active tuberculosis, tuberculosis case finding among people with HIV, and provision of treatment for both diseases. Estimates of tuberculosis and HIV treatment coverage is over 90% and substantially exceeds global and European coverage. 93% of TB patients are screened for hepatitis C, 94% of TB patients are screened for HIV, and about 96% of people live with HIV are screened for hepatitis C virus. As you are all well aware, Georgia was one of the first countries which launched hepatitis C elimination program in 2015 with the support of US CDC and commitment of Gilead Sciences to donate highly active direct-acting antivirals with the aim to reduce HCV prevalence by 90%. So far, we already treated about 80,000 chronic hepatitis C patients with very high cure rates, about more than 99%. We saw a remarkable progress, namely in 2021, we conducted together with US CDC, a repeated seroprevalence survey, which showed a significant reduction of hepatitis C prevalence from the baseline 5.4% to 1.8%. So it means that we are very close to elimination of hepatitis C, and we hope that by 2025, Georgia will become one of the first countries to eliminate hepatitis C in the country. One of the best demonstrations of active case finding was an innovative project on integrated screening and detection of tuberculosis, hepatitis C, and HIV infection. So this was one part and innovative project within the hepatitis C elimination program. The project ensures active case detection of HCV, HIV, and TB at the primary healthcare level through large-scale screening, including door-to-door outreach. An integrated TB, HIV, HCV screening project at primary healthcare centers was piloted in one of the most highly affected regions of Georgia, Samegrelo region, in April 2018, with the financial support from the Global Fund to Fight AIDS, TB, and Malaria. The comorbidities and approach was selected through wide stakeholder consultations based on joint burden, universal coverage of all three programs, opportunities created by the hepatitis C elimination strategy, high-level COVID commitment, and funding availability. So the objective of this project was to improve case detection of triple infections, hepatitis C, TB, and HIV at the primary healthcare centers in the country of Georgia. It was very important to have local public-private partnership, and fortunately it was established for effective integration of these three diseases in primary healthcare centers. Local government committed and allocated budget for incentives related to screening coverage. Integrated TB, HIV, and HCV screening protocol was developed. Over 450 doctors and nurses, as well as district quality managers, were trained. The integrated screening program has allowed about 60% increase of the local population number screened on HCV infection. The integrated model has also allowed considerable increase in TB and HIV screening also. Namely, for example, compared to 2017 in this pilot region, 192 presumptive TB cases were identified and referred for further confirmation and treatment, and the linkage was wonderful, compared to 55 presumptive TB cases in that region in 2017. So this project enabled both the development of a sustainable public-private partnership for effective integration of these three diseases and early disease detection, and the decentralization of diagnostic services at district level at non-specialist facilities. Based on the promising results of the pilot project, this program was rolled out in 2019. However, unfortunately, COVID-19 pandemic significantly affected the overall performance of Hep C elimination program, including integrated project. But we hope that starting 2023, and we already started to accelerate this project and accelerate the progress of hepatitis C elimination program, which can serve as a locomotive program for HIV and TB programs as well. And we hope that lessons learned from the Georgia's hepatitis C elimination program can inform programs in other countries striving to eliminate HCV and to end tuberculosis and HIV epidemics as public health threat. So I will stop there. Thank you for listening, and I'm ready for the questions.
Okay, thank you so much, Dr. Akaki. Again, very encouraging. Congratulations for such wonderful progress in integrating TB, hepatitis, HIV screening in Georgia. Again, I think the Q&A is available for colleagues to post questions. We will try, hopefully, to take some of them live, but in case we are not able to, we invite the panelists to also try to respond in the Q&A. So we will move on to just get a very brief preview into the framework that we are launching today. If that has already not been done, I'll request one of my colleagues to put the link to the framework in the chat so that people can also have a look at the full document. So for this session, I will now hand over to my colleague, Dr. Kerry Viney, who will be presenting some basically highlights from this framework. Dr. Viney is a team lead for vulnerable populations, communities, and comorbidities unit. Kerry, over to you.
Yeah, thank you very much, Farai, and hello everyone, and thank you to the panelists already who have spoken very nicely about either the lived experience or the programmatic work that they're doing on TB and comorbidities. So we're going to shift gear a little bit now, and I'm actually going to talk about the WHO framework for collaborative action on TB and comorbidities, which is what we're launching in this NTB webinar today. Let's just see if it moves forward. Yes. Great. So I think Dr. Kasayeva highlighted this, but of course, there are a number of drivers of the global TB epidemic. And this slide just shows the Global Tuberculosis Report, the latest one for 2022, which was published in October. And it highlights the 5 main health-related risk factors and drivers of the TB epidemic globally, which we've already heard about, but they are alcohol use disorders, diabetes, HIV infection, smoking, and undernutrition. Now, collectively, these risk factors accounted for about 45% of new TB episodes in 2021, and their contribution is published each year in the Global TB Report, so I encourage you to have a look at that. Now, of course, there are many other comorbidities that are important. I think it's important to talk about mental health and substance use disorders, which are associated with an increased risk of TB treatment delay, drug-resistant TB, loss to follow-up, and death. And of course, depending on the country context, there are a number of other comorbidities and risk factors that are associated with TB that will be important to address. Now, I think many of you on the call will know that collaborative TB HIV activities and the management of comorbidities do sit firmly within Pillar 1 of WHO's End TB strategy. So Pillar 1 is integrated, patient-centered TB care and prevention. But of course, Pillar 2 for bold policies and supportive systems, and Pillar 3, intensified research and innovation, are also highly relevant when we're talking about TB and comorbidities. Now, the importance of addressing TB and comorbidities, again, is underpinned by various United Nations high-level meeting commitments on HIV, of which there have been 2, TB in 2018, another one coming up next year in 2023, NCDs in 2021, and universal health coverage in 2019. And in these high-level meeting commitments, the importance of strengthening integrated care of TB, HIV, non-communicable diseases, tobacco, substance use disorders, malnutrition, and mental health in the context of universal health coverage is emphasised. Now, to respond to this, and the subject of our webinar today is the Framework for Collaborative Action on TB and Comorbidities, which has just been launched by WHO's Global Tuberculosis Program. Now, the goal of the framework overall is to decrease the joint burden of TB and comorbidities in line with the NTB strategy targets that we've just spoken about, the United Nations high-level meeting commitments on TB, NCDs, HIV, and universal health coverage. Now, you can see here that the framework has a number of objectives, and they are to establish and strengthen collaboration across health programs and across sectors to deliver people-centered services for TB and comorbidities, to provide guidance on assessment, planning, prioritization, scale-up, and evaluation of people-centered services for TB and comorbidities, and finally to facilitate the scale-up of WHO recommendations on TB comorbidities and health-related risk factors, and also those that relate to poor TB treatment outcomes. And we'll talk a little bit more about them in a few slides. Now, I think Dr. Kaseyeva highlighted the fact that the process of framework development has been quite extensive. So to inform the framework, evidence was gathered from the literature, including a literature review, during consultations with national and regional staff, and through interviews with TB survivors and key stakeholders. A policy review was conducted in 2020 to look at the uptake of WHO recommendations on TB and comorbidities within both the national TB strategic plans, the national guidelines for TB, and the national strategic plans for the respective comorbidities. We did a systematic review on the barriers and enablers to collaborative care for TB and comorbidities. This was followed by focus group discussions with countries. We had 16 countries represented, many who are on the call today. And we also undertook interviews with TB survivors and involved representatives from the WHO Civil Society Task Force on TB, as well as other TB survivors, to ensure a people-centered approach. Now, the findings and the framework were then reviewed at a WHO convened stakeholder consultation, and I think there will be some of those colleagues on the call today, so thank you again. And then finally, it was reviewed by expert peer reviewers. Now, the framework is organised into these following 5 sections that you can see in the circles here on the screen, each of which lists key activities for scaling up collaborative action on TB and comorbidities. So you can see that these 5 sections are firstly to strengthen governance and accountability for collaborative action, to conduct an analysis of access to quality services for TB and comorbidities, to coordinate planning and resource mobilisation for collaborative action, then to implement and scale up people-centered services for TB and comorbidities, and finally, but importantly, to strengthen monitoring, evaluation, and research. And as I mentioned, for each of these 5 domains, if you read the framework, there are a number of activities suggested for each of these domains to achieve the objective of collaborative care. Now, there are also a number of interventions included in the framework. So this slide just shows the WHO recommendations that currently exist for comorbidities and various health-related risk factors. So in fact, there are a number of WHO recommendations that are currently available for countries to implement, including on COVID-19, where WHO issued an information note about screening and about access to care for TB patients during the ongoing COVID-19 pandemic. Now, unfortunately, we don't have much time to go into the case studies, but also included in the framework are a number of case studies on TB and comorbidities. So I would encourage you to have a look at the framework and to read those case studies, and we've also had some of those presented today. A couple of the case studies that I just wanted to highlight is one on collaborative action on TB and diabetes in Mexico, where bidirectional screening was implemented. Another one on TB, HIV, and opioid agonist maintenance therapy in prisons in the Republic of Moldova. And finally, another one on addressing TB and mental health in North Lima in the community in Peru. And there are a number of other case studies also included in the framework, so I encourage you to have a look at those. Now, just to briefly conclude, the framework, of course, is not a document that will stand in isolation. There are a number of WHO guidelines and recommendations and other guidance documents that already exist on mental health, on managing TB in people who inject drugs, on nutrition, diabetes, cigarette smoking, and HIV, of course. We are currently in the process of reviewing all of this guidance, and we will expect updates from the Global TB Program on TB and HIV, TB and diabetes, TB and mental health, and TB and undernutrition over the next 2-year period. These will be incorporated into WHO consolidated guidelines on tuberculosis and comorbidities, and will be complemented by a WHO operational handbook on the management of TB and comorbidities. And when these documents are ready and finalised, they will be available on WHO's TB knowledge sharing platform at the link you can see there below. So with this short presentation, I would just like to conclude with acknowledgements and thanks. I'd like to thank all of the experts who were consulted during the process of developing the framework, those who participated in focus group discussions, the stakeholder consultation, external review, including the people with TB who were interviewed. I'd like to thank the technical consultants who provided support to WHO, our WHO staff across all 3 levels of the organisation, and the departments here at headquarters, and finally our funding, technical and implementation agencies and partners. I'm happy to answer any questions about the framework, and I will hand back to our chair. Thank you very much.
Okay, thank you so much, Kerry, for that brief but quite informative overview of the contents of the framework that we are launching today. So once again, the Q&A is available. In case there are any questions, please do post them. The link to the framework as a publication is also available in the chat for those who may want to also take a look at the framework. So we'll now switch gears, and for the next session, I will be handing over to the moderators who will take us through the next panel discussion. The 2 moderators are Dr. Stavia Turiahabwe, who is the National TB and Leprosy Program Manager for Uganda, and Dr. Silvana Luciana, the Unit Chief for Non-Communicable Diseases, Violence and Injury Prevention with the Pan-American Health Organization. So I will hand over to the 2 moderators. The floor is yours.
Thank you. Thank you very much, Faria, and congratulations to you and the WHO team for today's launch of the new WHO framework for collaborative action on TB and comorbidities. And thank you to all the panelists who presented some of their experiences from Zimbabwe, India, and Georgia for sharing their work and inspiring us on having a more collaborative approach to TB and comorbidities. And I'd also like to give a special thanks to Ashna for her very compelling and clearly articulated intervention on the impact that TB has had on mental health, just to really take the point home that we do need to have a more people-centered approach to care for people with TB and comorbidities. So in this next session of the webinar, we're going to delve into ways in which this new WHO framework can be used and applied to improve the management of people with TB and other conditions. And we're going to hear from our main partners, from people from the Stop TB Partnership, the Global Fund, USAID, as well as the WHO directors from relevant programs on NCDs, on mental health, on HIV, hepatitis C, and sexually transmitted infections, who are going to share their perspectives on how we can catalyze this collaborative action across programs to ensure that TB and comorbidities are approached through a strengthened people-centered manner in improving health services. So we're going to begin our discussion, and I'm going to invite Dr. Mohammed Yassin from the Global Fund, who's the Senior Advisor for Tuberculosis, to talk to us a little bit about what opportunities might exist through the Global Fund to strengthen people-centered services for TB and comorbidities. Dr. Yassin, over to you.
Thank you, Ilvana. Good morning, good afternoon, good evening, everyone. Thanks for WHO for inviting us, and again, congratulations for developing this important framework. I just quickly want to highlight the opportunities from Global Fund side, given that we are already supporting countries in addressing those comorbidities beyond TB. One opportunity, the Global Fund strategy, which is actually on maximizing the people-centered and integrated service systems for health. That is to maximize the impact and for resilience and sustainability as well. So addressing comorbidity, people-centered approach, integration is already part of our strategy. The second one is we already have policies and guidance on comorbidities, that's beyond TB, HIV, malaria. There are comorbidities and co-infections, which are critical. If we are really going to end these three diseases, we need also to address those comorbidities. So there are already policies and guidance on countries to access a Global Fund resource to address some of the comorbidities, including undernutrition. TB, HIV has already been part of the Global Fund strategy and the policy for countries to request a single funding request for TB, HIV, and joint programming for at least countries with the highest burden of TB, HIV. As you all know, we have been supporting countries in addressing COVID and tuberculosis, and that's overall as part of pandemic preparedness and response. So there are already ongoing activities, opportunities for countries to benefit from Global Fund support, because the flexibilities are there and we understand resources are there. And otherwise, diagnosing and treating only TB may not be leading us to ending the disease. We need to address all the social determinants and the comorbidities which contribute to increased TB burden, but also complicate the response in TB. This includes mental health and other infections as well. The third one is, as you all know, we had one of the largest replenishment, the seventh replenishment. We managed to raise 15.7 billion for the next 3 years. Given the current context and complex situations, this is really a great success, and we are expecting countries to come with their funding requests next year. And we just finalized all the information, not the modular framework. All the tools are already in our website, and you see that there are opportunities and flexibilities within a Global Fund support to go beyond the three diseases, beyond TB, and addressing comorbidities, co-infections, and working with others. And one of the new modular module we have incorporated is in collaborating with different sectors. So we're including private sectors, the communities, and other sectors as well, so that we can address TB as part of collaborative effort. And for that, I see a lot of opportunity, and we all look forward to work with all the partners and the country programs. And we just want to encourage you to consider beyond the three diseases, we consider comorbidities opportunity within the Global Fund. And for that, we are ready to work with you, and we look forward to implementation of this framework. Thank you very much. Over.
Excellent, excellent. Thank you very much, Dr. Yassin. And certainly the Replenishment Fund offers tremendous opportunities for countries to develop proposals and ensure an integration of TB and comorbidities in their applications. So we look forward to helping to support member states throughout the world in preparing the applications and ensuring this integrated approach of TB and comorbidities. Thank you, Dr. Yassin. So next, we're going to turn to USAID, and Dr. Amy Bloom, who's the Senior Technical Advisor for the TB program, is here with us. And USAID recently launched their TB strategy for 2023 to 2030. So the question to you, Dr. Bloom, is how does this strategy address TB and comorbidities, and what opportunities do you see to utilize the WHO framework in the strategy's implementation? Over to you, Dr. Bloom. We may be having connection problems with Dr. Bloom. I saw her connected earlier. Okay, it seems that we're having difficulties with Dr. Okay.
Can you hear me?
Yes, we can hear you now.
That's great. Okay. Sorry, I have been having some problems connecting today, so I'm sorry I missed some of the earliest part. It's been a while to get on, but thank you so much for inviting us to speak today for a few minutes on the topic. And I do want to congratulate you on this really important and very practical document, which I know will be critical to improving TB and general health outcomes for those most affected. So just a little bit on our new strategy, which covers the years 2023 to 2030. It's very short and high level, and it will be followed, for those of you who have looked at it, just so you know, with a more detailed implementation plan. The plan itself will also be quite broad, so that it's adaptable to more specific populations with different risk profiles. You know, when I was thinking about this, it struck me that we're kind of talking about comorbidities now the way we, I remember a few years ago where there were people chanting about no more living with HIV and dying of TB. And I think that we're also now looking at it more broadly and saying sort of a bit of the converse, no more, you know, treating and successfully approaching TB, but only to have people die of their comorbidities or be really ill with them, as well as being very cognizant that comorbidities are important to any individual's susceptibility to infection, the course and recurrence of their disease, and potential mortality from TB. So in our strategy, we've always been, you know, thinking about these things, but in our new strategy, we are more direct in acknowledging that beyond the essentials of detection, diagnosis, treatment, and prevention of TB, we're really looking at successful outcomes and preventing further transmission by looking also at the comorbidities, particularly the 5 health-related risk factors, but also that we need to do a better job of addressing the role of stigma and underlying psychological comorbidities and the mental health consequences of TB and TB treatment if we're going to reach our desired outcomes. Because we all know that TB preys on those who are at greatest risk, whether it be medically, socially, or economically, and we can't view it in isolation from these factors. So it's important that our TB programs are more holistic and more comprehensive. At the same time, while we want people to receive their care in a very person and people-centered way so that it's much more integrated and coordinated, we understand that the level of funding that we have and the directives that we have for our funding are for TB, which is why coordination with other programs and reaching across those lines is particularly important and kind of the key to success. One other thing I did want to mention is that we're also looking at the next layers out, sort of like an onion. There's TB at the core, the medical risk factors, and then the next layers out of socioeconomic and other determinants like climate change, which we know has both direct and indirect impacts on access and quality of care. It can be an extreme weather event, or it can be planning for the continuation of TB services during a climate crisis or a pandemic, as we saw in COVID, which clearly exposed our vulnerabilities, while at the same time, I think, showcasing the TB platform, particularly for respiratory diseases, which is likely to be our next pandemic as well. We are also cognizant and trying to figure out how we position ourselves, given that the impact of poverty, urbanization, overcrowding, and high levels of pollution also impact TB at every stage. So the TB community, the TB programs need to be involved in the conversations about these things, which may seem a bit distal to TB, but really are not. So just to say that during the duration of our strategy, we're really determined not only to address the issues that most directly impact TB, like appropriate diagnosis and treatment, but to work across disease entities and broader entities to address the comorbidities that influence TB and the more distal determinants of TB morbidity and mortality. And I really think that this framework is very practical and could be very, very useful in doing this most effectively and efficiently. I'll leave it at that. Thank you.
Great. Thank you very much, Amy, for those reflections and for highlighting that the coordination across disease programs and with the social determinants of health are really key to the success of reducing the burden of TB. And so in this next segment of the webinar, we're going to turn to our WHO directors from different programs to talk specifically about that cross-programmatic collaboration with TB. And I am going to turn now to my co-moderator to facilitate this discussion. So I'd like to introduce Dr. Stavia Turahabwe, who is the National TB and Leprosy Program Manager in Uganda. Over to you, Dr. Stavia.
Thank you so much, and thank you, first discussants for this panel. I want to congratulate WHO on this launch. It is an important addition to the TB response globally and to us as countries. We are going to focus, like you've said, on the WHO directors. And first, I'm going to call upon Dr. Benti to this, who is the Director, WHO Department of Non-Communicable Diseases. Dr. Benti, we have seen a strong commitment and political support for the response of non-communicable diseases in the past few years. Including at this year's World Health Assembly. What opportunities and low-hanging fruit in the non-communicable diseases response will help countries advance the joint response to TB and diabetes mellitus? Over to you, Dr. Benti.
Thank you very much, Dr. Stavia, and congratulations to Dr. Teresa, the whole team, and I would say to the whole world. And I think what I've learned so far in this work, but very much from the people with lived experience in this panel, is that comorbidities are not a theoretical kind of exercise. It is reality on the ground. And I think we just exchanged a little bit around this table here that, you know, for us at WHO, this is not new, but it's very new that we are able to work so closely together. But when we listen to countries and people affected by this is reality. So in my view, there is no excuse. So how can we utilize different initiatives and political commitments? I think, first of all, we just have to. And it was mentioned that for NCD, it has been 3 high-level meetings in 2011, 14, 18 at the UN General Assembly. And we are now preparing for the 4th high-level meeting in 2025. And at the same time, the tuberculosis community, and I would add also the universal health coverage community, are preparing for the high-level meetings. So low-hanging fruits, I'm not sure, but at least it is an obligation for us to really highlight the need for addressing comorbidities at all these high-level meetings. We need strong language because we need an obligation and a commitment to measure, to get data, as we have heard today, to act on comorbidities. I think the world has too long thought about, the Millennium Development Goals really helped us to focus on TB, malaria, HIV, while now when we see the epidemiological shift towards also at the same time non-communicable diseases, we need data that show this. And I think you have spoken about it. So there are many ways. So first of all is to join in, have strong language coming out of these 3 high-level meetings, TB, UHC, but also NCD. So of course we have to trust the member states that they see this, but we also know that we need to provide knowledge and data to really make that happen. And I think the second is to really look into integrated care, as was mentioned. We cannot have many health systems. We need to have one health system that really respond to whatever disease people have. And the reality of the fact in many countries is that TB has a better developed health system or response than NCD have. So I think I have to say that we need to join forces with you on the ground, but we will come with hopefully also both resources and knowledge to join you in this. So I think more concretely, it is really to set up the coordination mechanisms for diabetes and tuberculosis, and also to conduct the surveillance, as I mentioned. So we have the prevalence, and also maybe we should start very targeted in the high TB burden countries, where we saw some figures earlier today. We should start where there is a means to really get to I wouldn't say a quick success, but we need to demonstrate success to be able to move forward. And then, of course, to intensify the detection of both TB and diabetes. And as was mentioned, I think it was Dr. Greda who said that even if you do that, you can see that maybe you can screen and have the diagnosis, but next step is how to treat. And again, I think we can join forces. We can learn from the TB community on how you increase the access to medicines and devices. And we need to do the same thing for diabetes. So I think I will stop there. I see many opportunities, but I also really sincerely feel the obligation. We are in this together, but more, we have an obligation for the single patient that actually have these diseases at the same time, what we call comorbidities. Thank you. And back to you, Dr. Stevia.
Thank you so much, Dr. Benti, on highlighting the key actions that need to be taken to advance TB and diabetes mellitus activities as part of comorbidities, joining hands with us at national level, making sure that we are collecting the data that is needed, putting in place resilient systems, coordination, and service delivery integration to identify the cases in both communities. Now I turn it on to Dr. Deborah Castell, Director, WHO Department of Mental Health and Substance Use. Now, people with TB have a higher risk of depression, anxiety, and other mental health disorders and substance use disorders. What, in your opinion, would be the key enablers for scaling up assessment and management of mental health and substance use disorders in people with TB, or AD, and vice versa? Over to you, Dr. Deborah.
Great, thank you. Thank you very much for this question. Sorry, colleagues, that I couldn't be there, but thank you, Teresa, for organizing this very interesting and much needed session and the launch of the document. Congratulations, the framework. I'm sorry. I think that the enablers for scaling up for mental health and substance use are similar to the core principles in the global TB framework for collaborative action on tuberculosis and comorbidities. And so this is positive because we are not suggesting something completely new, but it's just to look at it from a different perspective. And the first issue to consider then is the political will. Decision makers should be aware of the role that the comorbidity with mental health, in this case with mental disorders and with substance use, plays in care for TB. And I'm not going to go through the details about how alcohol will impact the risk of TB or TB and depression, so eloquently explained earlier by Ashna in the beginning of this session. And thank you, Ashna, for sharing your experience with the world. We need more of that to make sure that we are talking about concrete issues and concrete needs and not just abstract words, right? But once policy makers, decision makers are aware, then they should know that there are concrete actions that can be taken to successfully integrate TB and mental health. And we have good examples, some were mentioned before, and some are coming, new case studies that we are working together with between the two teams to make sure that we represent properly what countries are doing. A second area would be, of course, building capacity. There are many different ways to make the integration of mental health into TB happen, depending on the context. There could be general health workers who work in high TB burden areas that could be trained in identification, assessment, and management of mental health and substance use disorders. But where there are resources to do so, a dedicated person trained in mental health identification and management could be placed directly in supporting TB colleagues in TB programs using a collaborative care type of approach. And by the way, we are coming soon with some modules that we are also developing together that are amazing, how clear and simple are presenting the challenges and the ways to intervene concretely. Then other areas could be ensuring people can have access to care, ensuring that countries will include evidence-based interventions for mental health within the UHC essential service packages or in social protection programs or schemes as well. And this is particularly critical since poverty is a key risk factor for poorer outcomes in TB and also is impacting mental health. And then community buy-in and inclusion of decision-making, community sensitization is needed, and the role then that communities could play is huge, including people with lived experience of TB and mental health, like we heard today, and is paramount on this. And so aligning these national priorities where mental health is included in relevant national TB plans, strategies, and vice versa would be the last one. I'm running because I know we are late, so back to you, and thank you very much for this opportunity.
Thank you so much for giving us the key highlights on mental health and TB and how this framework comes in handy. We'll take it on quickly. We want to look at what lessons can be learned from the TB-HIV response to strengthen data-driven people-centered services for TB and comorbidities. And to give us a synopsis here is the Dr. Meg, who is the Director of the WHO Department of Global HIV, Hepatitis, and Sexually Transmitted Infections. Dr. Meg, you're welcome.
Thank you very much. And I want to thank you very much for the invitation to be here with you and to congratulate the team and Dr. Casavia, as well as the entire team and our team as well, because I know we were working with you on this for launching this framework. And I think what I would start with is I'm really happy to see the ABCDE, and I think everything that we do in HIV, hepatitis, and STIs really can touch upon all of those elements of the framework. And I was also very excited to hear that we have examples that are not just TB and HIV alone, but we're really looking at the person-centered, the people-centered approach, where we're looking at TB, HIV, and hepatitis C, for example, in the prisons, or as well as in Georgia, into primary care with hepatitis C. Because I think we, just as Dr. Bloom was saying, we can't have TB and then die from HIV, we say the same thing. We can't save somebody from HIV and their long-term illness of HIV and then have them 5 years later die of TB, die of hepatitis, die of monkeypox, die of COVID. And I think we're all looking at the fact that we have to, A, do more with limited resources, but B, ensure that the person is corely at the center of everything that we do. In terms of HIV and TB, we've made a huge amount of progress, which I think is exciting. We have seen that those TB HIV collaborative activities that started in 2012, I think have moved the needle, maybe not 100% to where we want it to be fully integrated, but we see it's high on the priority of countries. In the Global Fund concept notes, it's already prioritized. In PEPFAR, it's prioritized. And just last year, we have seen a decline of 62% of the deaths among people living with HIV due to TB. So TB is one of the leading causes of death among people living with HIV, but we can control this and it is declining. There are other infections that we haven't dealt with, and what we have looked at now for HIV is what happens with the advanced HIV. When somebody comes in, they have a low CD4 count, they've never been engaged in care. Not only are they the ones at greatest risk for death from TB, they're the ones at greatest risk from death from cryptococcal disease, from monkeypox, from COVID, from all those other infections that affect somebody who's immunosuppressed. So where I see that we've had incredible progress has been around this scale up of TB preventative treatment. And we're starting to see that short course TPT is being implemented. Hopefully that will end up with saving many lives. And we're seeing quite a bit of screening and ensuring that people living with HIV and living with TB get the right treatment. The drugs are now much more compatible, and I think we can have those treatments happening simultaneously when in the past they weren't necessarily being taken in the most efficient way, and we would lose people along that pathway if we had to not give treatments at the right time. So overall, I guess we're coming to the end, I think, of our session. We want to ensure that countries can adapt these new framework, but also look at what we call the differentiated models of care, where in every setting you can have the who, what, where, and when, meaning it could be that the care for TB and HIV is delivered in the community, could be delivered in the facility, it could have expert clients delivering care. We could also ensure that there is reduced time that people have to come into the clinics, because when we go to self-care and taking on sort of out of facility care, that's how we've been able to be very resilient during the COVID period of time with some of the HIV services. And that can be, I think, further extended into TB care and other comorbidity care. And lastly, I think we have to ensure, as all have said, that the data are collected, and then at site level we have high quality data, so that if we have to shift an approach, if we need to be delivering as a one-stop shop in primary care, or we need to be delivering where they're facilitated referrals, that we can effectuate change at the facility level to make sure that people have the best approaches possible. So I just am excited to hear this, and we just, it's also very exciting to hear and see the case studies that have looked at several comorbidities such as Hep C, with TB and HIV. And I think more of that will need to come out, and more of that will need to show that we're actually, these disease-specific programs are providing primary health care and can be considered the basis of a primary healthcare approach in some countries. So with this, I pass back to my colleagues and say thank you very much for having us here.
Thank you so much, Meg, and for highlighting those key areas. People-centeredness, I think, is the way to go. All these conditions affect one individual that we are looking at to serve for TB and for other comorbidities that we are talking about. We have seen a lot of gains in TB HIV. I want to now hand over back to the chair. Over.
Okay, thank you so much, Dr. Stavia, for moderating the session. And we do apologize for going a bit over time, but we really appreciate that colleagues are still online and still actively engaged in the Q&A. And also, I would like to thank Dr. Luciana, who also expertly moderated this session. So we've come to the end of this webinar. Unfortunately, we are not able to take some of the questions live, but I think my colleagues and other panelists have also been trying to respond to some of those. In case we do not respond to them immediately, we will still take note and try to follow up with you. So in case you have asked a question and not included your name, please do include your name and email address so that we can follow up with you. So I'll now hand back to Dr. Teresa Kasaeva, the Director of the Global TB Program, to give her closing remarks for this webinar. Over to you, Dr. Teresa.
Thank you very much, Farai. Yes, indeed, we are running out of time and close to the end of this important webinar, but it's good to see that our audience is still with us, and more than 100 people stayed with us for almost 2 hours. It's really inspiring, and I hope that with joint efforts, all together, we can push forward this agenda of people-centered approach for better treatment outcomes, for shortening time from falling ill to the successful treatment and for healthier life. This is all in our hands, and jointly we really can make the difference. We've seen it from the COVID-19 pandemic. We will be able to demonstrate it, and we have already these best practices and experiences. We are not starting from the scratch. And indeed, dear colleagues, it's not a matter of choice. It's just the way we must go, and to implement, to go from the declared principles of people-centered approach and universal health coverage to their practical implementation. And we can make the difference, and we must do the difference. Indeed, TB programs in many countries, especially high TB burden countries, could be used as an entry point, as well as HIV programs, and there we can bring other programs and colleagues to address in the most comprehensive and integrated way people needs. So with a huge enthusiasm and inspired by the examples of from the countries, inspired by the leadership and advocacy of our survivors, TB champions. Ashna, thank you very much. Thank to our excellent co-facilitators, and of course I can't miss this opportunity to thank my amazing colleagues, directors of other departments of the communicable and non-communicable diseases, working hand in hand here for your support, engagement, and leadership. And also with your permission to my dedicated team working under supervision of Farai, Annabelle, Kerry, all of you, Natasha, thank you very much for making it happening. And I can't miss opportunity and say that My friend Luchika and colleague was not unfortunately able to connect, but she has tried to do her best. But this is another side of remote meetings. Hope next time we will be able to meet in person and to have live and interactive discussion. But I know that Luchika is with us, sharing her greeting and words of support to all of you. Please stay safe and all the best to you. Continuing working.
Thank you very much.
Thank you.
Thank you. Congratulations again. Bye-bye.
Well, thank you.